Good morning, everyone. I'll be presenting for clinical case discussion today on behalf of Medicine 5. So, coming to the history, a 56-year-old gentleman, Mr. N from Tripura, working as a cleaner in a municipality from Tripura, West Bengal. He came with complaints of coughs in 6 months, breathlessness in 6 months, loss of weight and loss of appetite in 6 months, giddiness since 20 days, imbalance while walking since 1 day, and blurring of vision since 1 day. So, history of presenting complaints. He was apparently well till 6 months ago when he developed cough, which was predominantly dry and had occasional scanty mucoid sputum. There was no associated hemoptysis, no increase in postural change, no increase in cough on lying down, no diurnal variation or seasonal variation. There was no improvement of cough with over-the-counter antitussives or MDA, which he was prescribed over the course of 6 months. He had breathlessness, which was insidious in onset, which has been more with exertion. He has an effort tolerance of around 1 kilometer on ground. With his, however, his breathlessness is more after climbing one flight of stairs. There was no history of orthopnea or waking up from sleep with breathlessness. He gave history of loss of weight and appetite over the past 6 months, which could not be quantified. There was no history of chest pain or pain on deep inspiration. There was no history of wheeze. 20 days ago, he developed one episode of giddiness, which was associated when he felt the entire room was spinning for around 20 minutes, which was continuous in nature. However, he was able to walk at this point of time and lie down on the bed. And this was not associated with sudden head movements or tinnitus. He had to be taken to a hospital for the same, and in an auto where he was carried by two people. After which the giddiness subsided over a few hours. There was no loss of consciousness, no jerky movements, no associated urinary or fecal incontinence at this point of time. The episode had subsided after the admission. He had similar episode 5 days prior to arrival.
Just 1 second. So these symptoms happened while he was traveling or in Vellore?
So no, sir, he's not come to Velo yet. He's at home at this point. Yes, sir. Yes.
Is that what brought him to the hospital now?
Sir, he was yes, sir. This recurrent episodes is what brought him to the to CMC, sir.
So are these recurrent episodes or a single episode?
So there is one episode 20 days ago, sir. Then 5 days ago he had one episode prior to coming here, and on arrival he's had another episode that I'll come to next, sir. So after arrival to Vellore, he had another episode of giddiness. This was associated with imbalance while walking. However, he gave history of swaying to both sides when he attempted to walk and needed support of his wife and relative to walk. He also realized that he had new onset double vision. He saw a nearby person as two standing by side to side, and when he attempted to climb stairs while coming to the emergency, he noted that the stairs was one above the other. However, when he closed his right eye, he could see normally and felt the vision was better. And generally, the vision was better when he was looking far away. His wife also noticed some drooping of the right eyelid. There was no history of altered behavior, confusion, speech difficulty. There was no facial deviation, drooling of saliva, difficulty swallowing,
Could
speech.
you just summarize at this point and tell us the analysis of your history? Yeah. Go back. Just summarize.
So I have a 56-year-old gentleman who has come with chronic cough and breathlessness with loss of constitutional symptoms like loss of weight and appetite, who's come with new onset, recurrent episodes of giddiness and neurological symptoms in the form of probably double vision and imbalance while walking, sir.
So which systems are being affected?
Sir, because there is no history of orthopnea and PND, I think the breathlessness and the cough is involving the respiratory system, sir.
So it's
and
primarily a respiratory problem.
Yes.
Main
Yes,
symptom that he's come with
Yes,
is a respiratory problem.
Yes, sir.
And what kind of respiratory problem are you thinking about?
Probably a parenchymal kind of a this thing. There is no pleuritic chest pain, and history wise, there is no wheeze to involve a airway disease.
So it's a disease of the lung parenchyma.
Yes.
Okay. Yes. Go ahead. What else are you thinking of? What kind of diseases are you thinking of?
Here there are, it's a chronic standing condition with the constitutional symptoms. So it is something that has been ongoing and which is causing loss of weight and loss of appetite.
So based on these symptoms, what differentials are you considering regarding the parenchymal lung disease?
So I can consider He's actually, I'm coming to the history. He's a smoker with significant smoking. So I will consider.
How long has he been
So
smoking?
he's been a smoker. He smokes BD, sir. So he smokes BD, 20 BDs daily for 35 years with a pack year of 35 and a smoking index of 700, sir. So that is
So he's been
significant.
a heavy,
Heavy smoker.
long-standing smoker.
He stopped since reformed
Yeah.
since this onset of symptoms, but prior to that, he's been smoking daily. So I would consider a lung mass as one possibility. I would consider tuberculosis still as a possibility.
Mass or a neoplasm?
Neoplasm,
So you're
malignancy
thinking
as
of
a
a lung cancer, the
cancer.
differential, and
Yes.
one and the other diagnosis.
TB still as a
Okay,
possibility.
so you're thinking uppermost of some chronic
Yes.
parenchymal lung disease evolving over a period of 6 months in a smoker,
Yes.
and a differential of a tuberculosis and a malignancy. Okay, and what other problems is he presenting with?
So 20 days ago, he had giddiness, which was persistent with room spinning kind of a sensation, sir, which had subsided by itself. So there was no, this is pointing slightly towards a central vertigo because I could not elicit any peripheral vertigo symptoms, no tinnitus, no other complaints at this point of time. So this could be a neurological symptom, maybe a central vertigo.
So when a patient comes to you with giddiness to the OPD or the casualty, no, what all causes will you think about? How will you evaluate that symptom?
So giddiness.
Not only neurological problems, no other problems can cause
Yes, sir.
giddiness as well. So what all are you thinking about?
Was there any sudden strain which he was doing, which could have triggered a vasovagal syncope kind of a
Okay, so is it a syncope?
syncope?
Okay, so how will you know whether the patient has syncope or not?
Was he having any recurrent cough in this patient? If
Now,
I
what
was thinking,
symptom will you ask for which clues you in to a diagnosis of a syncope?
the feeling of blackish,
That's very important.
yes,
The blackout, the
black.
symptom of blackout and syncope, which is conclusive of that the person have a neurocardiogenic or a vasovagal syncope. What else can cause giddiness?
Certain arrhythmia could cause giddiness, but
Okay, what are going in the OPD? What is the common causes of giddiness?
peripheral vertigo can cause
No,
giddiness.
even more common than that. Can anemia cause
Yes,
giddiness?
yes,
Okay, so we have other causes. A person who could be anemic, a person could have postural giddiness also, even
yes.
without a syncope, right? So all these can cause. So what will clue you into the diagnosis of a neurological problem or a audiovestibular problem?
One hearing, I have to any new hearing
Okay, so
change.
was there a vertiginous sensation?
He said room spinning, sir.
Room spinning. And so how will you distinguish between a peripheral and a central cause of vertigo?
The presence of this sudden head movements triggering of this giddiness could be towards a peripheral vertigo, sir, and presence of tinnitus could be towards a
So he
peripheral
didn't
vertigo.
have those.
No,
No
sir.
hearing loss.
No, sir.
Okay, proceed. So you're thinking, and here he had some other neurological symptoms
That was
also, right?
late.
What
Yes.
are those?
So later, sir, he also had, after coming here, he had again an episode of giddiness, and he had found it difficult to walk also at this point of time. He was swaying to both sides and requiring help from his bystanders, and he felt that there was double vision, sir. The double vision was both horizontal and vertical from the history. He felt that the stairs was one above the other, and when he was looking
So what
closer,
does that tell you? Where you person seeing double? What do you call that symptom?
diplopia, sir. I mean,
Okay, he's having diplopia. Was it moving or it was just a double object?
it was not moving, sir. He said that it was just two. So he
he
saw
had
the same stair above. When he tried to keep his feet, his feet fell down,
so
and
he had giddiness and diplopia,
yes, sir,
and
yes,
he had swaying also, right?
yes, sir.
So what does that suggest to you?
Uh, the swaying could mean that there is a brain, definitely a brain stem, posterior circulation, I would think of, and maybe cerebellum could be involved because of the swaying.
Okay, so is the giddiness itself causing swaying, or is there some other problem of imbalance, like a balance problem, like in coordination or a cerebellar involvement? But all these symptoms are acute, right?
Acute, sir.
And they're resolving.
Yes, sir.
Is that correct?
Yes, sir.
Okay, so what kind of problems can cause these symptoms of giddiness and vertigo, of diplopia, of ataxia, imbalance? What do you think? And resolving, right? So what is your analysis of the
Because
symptom?
of the onset being extremely acute, vascular event would be on the
So
top
there's
of
a
my top.
transient resolving neurological illness. So the first thing we are thinking of is it like a transient ischemic attack, which is resolving, right? So that is uh, yes, okay. So he has come with the parenchymal symptoms of a respiratory problem. He's developed some reversible neurological problem, right? Which seems to suggest a central problem in the brainstem is
Yes.
what you're thinking about, no?
Yes, sir.
And so how do you relate these two? Are they related? Are they unrelated?
They to unify them, we will like he has a long-standing illness, so long-standing respiratory symptom. Uh, if we were thinking in terms of a neoplasm, he could have a hypercoagulable state that could explain him being prone for a stroke. But underlying, he also has hypertension since the past 4 to 6 months, which he knew only now. But maybe he already had these risk factors as being a smoker and also have being a hypertensive. He already has a vascular risk factor.
Thinking more of a vascular cause. Okay. So if you take the two diagnoses that you are considering of TB and of malignancy, if a person, how do you relate the neurological symptoms to a diagnosis of TB or malignancy?
If I'm saying with TB, whether there is a disseminated TB which could explain a CNS TB that could explain new onset involvement, or there is TB endarteritis causing a stroke. So that could explain the TB's disseminated TB involvement. If it's lung, whether
So is
there's
that a common symptomatology in TB of neurotuberculosis that you can get diplopia, giddiness? Are they common symptoms? They are not. No? What's the most common presentation of CNS TB?
meningitis.
Meningitis. And then we know that vascular can happen, but it's unusual to have a vascular event without the presence of meningitis.
Okay.
Tuberculomas, can they present like this?
Yes.
I mean, though we know that tuberculomas can occur in many parts of the central nervous system, particularly the cortex, the cerebellum, involvement of the brainstem itself is low. So the symptomatology does not really suggestive of a diagnosis of TB in the brain. No?
Sure.
What about malignancy?
That also it can be malignancy itself being a one hypercoagulable state. The other possibility is a leptomeningeal carcinomatosis kind of a picture, or a paraneoplastic encephalitis. But he didn't have any confusion, drowsiness, any of those to say an encephalitis per se. The other thing, so the two possibilities, either the malignancy made him more prone for a vascular event, or a possibility that the malignancy is now involving the CNS also.
So you're saying that there could be different
They
causes of
could be.
CNS involvement in a patient with a malignancy,
Okay.
but these symptoms are not very characteristic of that. But so you're thinking that they are probably two different things which are happening, is it?
Okay.
Proceed.
There was no history
He
of.
had ptosis also.
Yes, sir.
Double
Partial
vision
ptosis.
and ptosis.
Yes.
So how do you relate the two?
So he had
Unilateral.
unilateral,
Okay.
sir. So I was because there's a partial ptosis with diplopia. Extraocular muscle, to be specific, third nerve could explain levator papillary superioris weakness with the diplopia, especially it being a binocular diplopia. When he closed one eye, he was feeling it was normal. So I thought that could explain both the diplopia and this thing, sir.
Can ptosis occur with lung cancer?
Yes, it can, sir. Paraneoplastic Lambert-Eaton syndrome, it can happen with bilateral, but it will be bilateral,
Any other
unilateral.
way? Can Fancos
It can
tumor cause
Fancos tumor with a Horner syndrome, sir.
Horner
Horner
syndrome?
syndrome.
So we don't, but this seems to be reversible. It's not
Yes.
like a,
Yes.
doesn't look like paraneoplastic syndrome.
There was no history of altered behavior, confusion, or speech difficulty. No facial deviation, drooling of saliva, difficulty swallowing, speech difficulty, hearing abnormalities, hoarseness of voice, dysphagia or pain or difficulty in neck movements. There were no history of weakness of upper and lower limbs. There were no numbness, tingling sensation, or spontaneous pain. There was no history of headache, seizures, or vomiting. No history of palpitations, postural giddiness, difficulty passing urine, or other lower urinary symptoms. Past history, he was diagnosed to have systemic hypertension 4 months ago. He has no history of diabetes, contact with tuberculosis, ischemic heart disease, or seizure disorder. He had multiple scaly lesions over the body and scalp since 3 years. It was diagnosed to be psoriasis, and he's been on and off on treatment for the same. Family history, there's no history of tuberculosis, no history of malignancy in the family. He's a smoker who smokes BD daily for 20 BDs for 35 years.
This occupational history.
So he's a municipality cleaner, sir.
Okay, so what kind of occupational disease does patients who are municipal cleaners, what kind of occupational diseases could they have?
He could have.
People fall into manholes, no, and become unconscious. What is that? That happens here also, no? Why is that? What is when people fall into manholes and fall unconscious? What is the syndrome? Asphyxiation, right? Asphyxiation due to what? That happens in patients who are municipal workers, right? So what other diseases can be there in patients who are people who are working in municipal corporation? What do they handle?
They could be handling toxic waste.
Yeah, waste of different kinds, right? So we often see tuberculosis in people who are. So can you? So we have to think of TB, other diseases. Now, are there any occupational diseases which increase the risk of lung cancer? What are they?
Silicosis.
Silicosis doesn't cause lung cancer.
Asbestosis.
Okay.
Sorry.
So, what are the occupations which can increase the risk of exposure to asbestos? Can manual workers also be exposed to asbestos? What kind of manual work can be associated with asbestos exposure? What is asbestos used for? What all is it used for? We use for low cost construction, right? What else can it be used for? It's used for insulation. Okay, so anything which is at high temperature, boilers, where we are transporting hot water. Okay, and when there is repair that is required for any of these industries, people can get exposed. There are also small industries in cities where people are exposed to asbestos. So we can actually ask for a more detailed occupational history and what is there any exposures that this particular person has. But they may be relevant to the illnesses that you are thinking about. Proceed.
So, summarizing, a middle-aged man with significant smoking history and recently diagnosed hypertension with cough, which is with progressive exertional breathlessness, along with constitutional symptoms, and new onset intermittent episode of giddiness, followed by acute onset diplopia and right-sided ptosis and imbalance while walking. Systems involved, it's a multi-system involving case, probably respiratory system and neurological system, with respiratory system being the primary and new onset neurological symptoms. The end of history. So at the history of, at the end of history, the differentials that most likely considered would be a lung mass or a lung carcinoma neoplasm with brain metastasis were paraneoplastic syndrome per a vascular event which was separate to it, disseminated tuberculosis as mentioned, and HIV with opportunistic infections, lymphoma which involves both lung and CNS, less likely sarcoidosis, small vessel vasculitis, bronchitis with brain abscess, very, very less likely because there were no symptoms.
So, what is the probability of different diagnosis here?
Um, Most likely considerations would be a lung neoplasm, sir. First, because of his smoking and because of
So
the fact that he has
probability of the
constitution.
first two diagnoses are the highest, right?
Yes,
so
sir.
what's your likelihood of lung cancer here? What's how much bet are you putting on it?
How much? Highly.
Quite high. What, 40, 50, 60? TB?
Mm,
10, 20. So all the other diagnoses are
very.
pretty unlikely here, right?
Yes.
So when we think of lung cancer and neurological symptoms, what are the neurological symptomatologies associated with lung cancer?
One is paraneoplastic lung cancer
Can you name some of the neurological syndromes associated with lung cancer? You had mentioned metastasis in the brain.
Sure.
So metastasis can happen in the brain, can happen in the spine. Okay, what else? What are the other paraneoplastic syndromes?
Lambert-Eaton syndrome.
What is that?
So, sir, they can have muscular weakness on that improves on repetition usually, and
What type of lung cancer is associated with Lambert-Eaton?
small
cell
cells,
cancer.
small cell
Okay.
lung cancer.
Yes. What other neurological symptoms?
Then they can SIDH,
Okay.
and then there can be hypercalcemia secondary
Okay.
to
So
PTH,
metabolic
RP.
problems causing neurological disturbance. What else? So you can get peripheral neuropathies, you can get proximal myopathies. Then you mentioned paraneoplastic encephalitis, right?
Yes.
So it can be depression of the sensorium, cognitive changes that happen with so myopathies, neuropathies, decline in the cognitive functions. There can even be a cerebellar ataxia associated with lung cancers. So all these are known neurological syndromes associated with lung cancer. So we have to think of all these possibilities here. You mentioned uh, leptomeningeal involvement.
Yes.
Did you say that? Yeah. What kind of cancers cause leptomeningeal involvement? How does that present? It's not common with lung cancers, particularly leukemias, lymphomas. They can be associated carcinomatosis of the leptomeninges. They may not present with a clear features like a meningitis, but they can come with depression of the sensorium, weakness. Okay, so it's not a very specific, but here there are no clues really to a leptomeningeal. Seems to be more a brainstem involvement, which is transient like a vascular. Any other comments? Proceed. But some more neurological syndromes you have to think about, right? So you mentioned Pancoast tumor.
Yes.
What are the neurological disturbances of Pancoast tumor?
They'll have Horner syndrome, sir.
Yes, and they have weakness of the hand.
Weakness
No,
of the hand.
which group of muscles are affected? Which nerve roots are affected? So what do you mean by Pancoast tumor? What is the other name for Pancoast tumor? So it's called the superior sulcus syndrome or superior sulcus tumor. Where is the tumor? Pancoast tumor?
Apical.
Yeah, it's in the apex of the lung. So why is it called superior sulcus tumor? What is the sulcus? When the subclavian artery crosses over the apex of the lung, that sulcus that forms, it's called the superior sulcus. So when there's a tumor in the apex of the lung, what are the structures that are affected? Neighboring structures, neurological structures.
Sympathetic chain.
Yeah, so the lower part of the sympathetic chain can be affected. What else? What are the neighboring nerves? The plexus?
Brachial.
It's a brachial plexus. And so what are the nerve roots adjacent to the apex of the lung? The lowermost part of the brachial plexus. So it's mainly the C8T1. So you can get weakness of the hand, sensory disturbance in the ulnar distribution. So we look for weakness of the hand, for sensory disturbance, all these which suggest a superior, and also for Horner syndrome. These are all the common neurological disturbances associated with lung cancers. Proceed.
Coming to the examination, general physical examination, respiratory rate of 18 per minute, normal saturation, BP, because he had giddiness, we had checked the postural BP, 150/90 on arrival, 3 minute 146/90, 5 minute around 150/90. Pulse rate of 104 per minute, felt at the right radial artery, regular. GCS.
When you his appearance, no, what did you notice about his appearance? When you looked at him, no, what did you see?
He's a thinly built gentleman.
Has he lost weight?
Yes.
He appears to have. What else did you notice? What about his shoulder?
That I mentioned.
Drooping of the shoulder. So he looked like somebody who's been through a illness over some time.
Yes.
He's lost some weight. He was not in distress. No?
Yes.
Vital signs, anything positive?
No, sir.
The general examination?
So general examination, he had grade 2 clubbing, sir. He also had a ball tongue with some oral candidiasis. He had bilateral axillary lymphadenopathy, soft. They were soft with around 2 into 2 centimeters.
Did he have parrot beaking or no?
And no parrot beaking, sir.
Look at the nail.
But that single nail I felt was more, but it was grade 2 predominantly.
Does he have only upper limb or low limb clubbing?
Only upper limb.
Upper limb clubbing. Is there any differential clubbing on both sides or the same?
Same.
So what specific types of clubbing are associated with lung cancer?
Grade 4. Grade 4
What
clubbing.
Do you mean by grade 4 clubbing?
Hypertrophic pulmonary osteo.
How will you pick that up?
By pressing, by giving mild compression to the wrist, there'll be severe pain because
So the patient will always have wrist pain associated with this. There may be some inflammation.
Yes.
So when you press over the wrist joint, there's tenderness. So this grade 4 clubbing is very conclusive of the diagnosis. It's highly suggestive of a diagnosis of a neoplasm, lung cancer.
Okay.
So here you found clubbing, which is makes the diagnosis of TB less likely, right?
Yes.
Proceed.
There were no external markers of TB, no features of Horner syndrome. So respiratory system.
Just come back. The size of your axillary node. Axillary node size.
2 centimeter into 2 centimeter bilaterally.
Group?
It's an anterior group, sir.
Anterior group. Significant or not significant?
Significant because.
Can axillary nodes be normally felt? They can be normally felt also, right? So small nodes may not be significant in this case, but you have to note it here. What other findings will you look for on general examination? Hands. You're looking for C8T1 wasting, right? What else you're looking for in the neck? One particular
dilated
sign.
veins. Dilated veins.
And one sign you want to elicit?
Pemberton's.
What is Pemberton's sign?
By lifting both of your hands, we're looking for SVC obstruction. Is there a compression due to the mass causing an SVC obstruction? So when we lift both our hands, there is the intrathoracic compression occurs, and there is flushing of the face and neck.
So how will you know when you see veins in the neck whether there is SVC syndrome? What sign will you get? What are there pulsations or there are no pulsations? So it's non-pulsatile neck veins which increase when you lift up. What other symptoms are associated with SVC syndrome? What happens when your SVC is blocked? No, what other symptoms happen? What are the other symptoms because of what happens to the face? Face becomes swollen. What other when there's a block in the SVC? What neurological symptoms will you get? can start getting headache. Okay, so these are all things that you have to look for. When a person has an SVC syndrome, what other symptomatologies are associated with obstruction of the SVC? Why does SVC syndrome happen in lung cancer?
Mediastinal compression.
Okay, so mediastinal lymph nodes, right?
Lymph
And they
nodes.
press on the SVC, they block the SVC, and you get the features of SVC syndrome. So, which part of the mediastinum do there have to be lymph nodes to cause an SVC syndrome? Mainly in the superior mediastinum. It's also called the superior mediastinal syndrome. So, what other symptomatology is there when you have lymph nodes in the mediastinum? What other symptomatology? To compress other structures, so you can get dysphagia. Okay, you can get stridor. So these are all features that can happen with the. So these are things that we have to look for. If the voice is hoarse here, what will you suspect?
Well, whether there is a laryngeal nerve involvement, laryngeal nerve palsy.
The recurrent laryngeal
laryngeal
nerve
nerve palsy.
palsy, which can happen again with mediastinal lymph nodes. Okay, proceed.
So on respiratory system examination, on inspection nostrils, there were no nasal polyps, no secretions. Oral cavity, there was lichen planus and dental caries were present. On inspection, there were no use of accessory muscles. There was drooping of the right shoulder as seen. There were no scars, sinus or dilated veins. There was no kyphoscoliosis. There was trachea was mildly deviated to the right. Apex beat was not
Was there
visualized.
wasting or no wasting?
No evident wasting, I felt.
Why did I ask that symptomatology? But whether you got wasting or not. What does wasting indicate?
Sir?
What does wasting indicate? Why is it
Wasting, there would
important
have
in
been,
general
is there a
exam?
neurological
What kind of
trauma?
respiratory illnesses cause wasting of the respiratory muscles?
Uh, like
So it tells you how long the illness is there. So
okay,
generally, acute respiratory process will
will
not
not come.
cause wasting of the respiratory muscles. Presence of wasting indicates that the illness has been there for a longer period of time. So here, wasting may indicate something like tuberculosis, which has been there for a longer time. Malignancies could have wasting, but may not have wasting also. So this is an important finding that we should look for.
Uh, no visible pulsations and no indrawing of chest. On inspection, the movements, upper anterior movements were normal, lower anterior, the right side movements were decreased, and lower posterior also right side movements were decreased. Coming to palpation, spine was normal, trachea was deviated to the right, apex was felt at the left fifth intercostal region and the mid-clavicular line. On movements, when movements were assessed in palpation, similar findings were reconfirmed. Mammary area and the infrascapular area, the movements were reduced
So
on the
on,
right
if you
side.
want to summarize the findings on inspection and palpation.
So he has trachea which is deviated to the right with decreased movements, respiratory movements on the right mammary and infrascapular region, indicating a lower and a lower anterior and posterior
Was
decreased.
there rib crowding?
Sir, no, I couldn't appreciate rip crowding, sir.
Okay, so when I examined, there's definitely rib crowding as well. So based on these findings, what are the conclusions you can draw?
Based on these conclusions, decreased movement on the right side with the uh, right-sided tracheal shift. I would consider that there is a underlying collapse, maybe, or a fibrosis. There could be, or a mass that could be caused a collapse on the right side. The
So
pathology is on
there's
the right side.
loss of lung volume
Yes, sir.
is there. So you have to think of either a collapse or a fibrosis. And so here, if there was wasting, it may suggest a fibrosis. Whereas if there was no wasting, it might suggest a collapse. Okay, proceed.
So coming to the measurements, transverse diameter of 32, anterior posterior diameter of 18 with a ratio of 1.7 centimeter. Chest circumference was 94 centimeters with the right expansion of 0.5 centimeters, which is reduced, and the left side expansion of around 2 centimeters. Spinocerebellar distance on the right side was 9 centimeter, left side 8 centimeters. Spinoacromial distance around 13 centimeters on the right, left of 12 centimeter. Coming to vocal fremetus, again the vocal fremetus was reduced in the right mammary, right infraaxillary, and right infrascapular and right interscapular regions, while it was normal on the left side. Coming to percussion, sir. On percussion, there was dullness which was noted in the right mammary, right axillary, and right suprascapular. I mean, right infrascapular, right interscapular regions, which was correlating to the vocal fremetus and her inspectory findings.
It's dull or stony dull?
Dullness, I felt, sir.
So so you said mammary and infraaxillary and infrascapular.
Infrascapular, interscapular.
Interscapular. Okay. That's overlying which lobes?
Right middle and lower lobes, I was considering, sir.
Proceed.
So auscultation, there was no on auscultation. There was decreased breath sounds in the mammary, infraxillary, infrascapular, and interscapular regions. There were no added sounds, no bronchial breath sounds, no wheeze or rhonchi, which were appreciated in any of these areas. Coming to vocal resonance, there was again decreased vocal resonance. BR was decreased in mammary, infraxillary, infrascapular, and interscapular regions, with normal vocal resonance on the other regions. Next.
So before we go further, so what are your conclusions based on your respiratory examination?
So based on the respiratory system examination, there was right-sided tracheal deviation there was right-sided shoulder drooping on inspection with right-sided tracheal deviation. There is decreased movements on the right side with decreased expansion, and there is decreased breath sounds with decreased VFVR on the right side, sir. You're probably indicating a right-sided collapse, probably.
So when we examine a patient with suspected malignancy, what clinical findings do we look for in the respiratory examination? Are there specific signs that we should look for? We've talked about some already, the features of Pancoast tumor, talked about SVC syndromes. Are there any other respiratory signs of mediastinal mass? Anybody? Respiratory signs of lung mass? We heard of the DS spine sign, the D apostrophe ESPIN. What is that? You listen for whispering petriloquy over the T3, T4 spines. You go see vertebra prominence, go about 3 or 4 spaces below that, and you listen over the vertebra for bronchial breathing or whispering petriloquy. So that is one of the, it's an older sign, but it is one of the signs of mediastinal mass. The other findings that you might get with lung mass are if there's a bronchial narrowing, you can get localized wheeze. Okay. So if a patient just has a lung mass, right, what are the respiratory findings? Not collapse, just a mass. What will be the findings?
There would be inspection wise
on percussion.
Percussion dullness, sir.
Okay, so it's localized dullness.
Dullness.
Okay, it may not be in a lobar distribution.
Sure.
So localized dullness, and you can either get reduced breath sounds, or sometimes when the mass is there against the trachea, you can actually get bronchial breathing. So these are the findings. But your findings were primarily that of a right-sided lung collapse, partial or complete collapse of the right lung.
Partial.
Partial. Okay, proceed.
Coming to the central nervous system.
Did you get any findings on the nervous system? Any abnormal
on
findings?
arrival, sir? Actually, he was my patient. So on arrival, he had findings, which is now resolving, actually, sir. So on his higher mental functions were normal. TCS 15/15, right-handed, conscious oriented. Memory was intact. Language and comprehension were normal. So on initial cranial nerve examination, he had right third nerve palsy. He had an eye which was down and out with ptosis, with difficulty in. This was there, and there was but no pupillary involvement at this point of time, sir. And the other cranial nerves were not involved. The power, bulk, tone were in the upper limb and lower limb were normal. The power in both upper limb and lower limb were also noted to be normal. Sensory system examination was normal, sir. The reflexes were 2 plus, plantars were bilaterally flexor. Cerebral signs alone, he had dysthyrokinesia, bilaterally both right and left. He had dysthyrokinesia, but there was no ataxic gait, no truncal ataxia, no difficulty walking, no nystagmus, no other signs of this thing, no pass pointing while doing finger nose test. So cardiovascular system, the AVP was not elevated. Inspection, no visible pulsations. Apical impulse was not visualized. Palpation, apex beat felt at the left fifth intercostal space. Auscultation, S1, S2 were well heard. Abdomen again soft, not distended, no tenderness, no hypersplenomegaly, no masses were palpable, no evidence of free fluid, and normal bowel sounds were heard. So coming to the summary of the history and examination, probably a unilateral parenchymal lung disease with trachea shifted to the right, decreased movements on the right side, decreased expansion and decreased vocal formatus, dull percussion, reduced vocal resonance, a probable mass lesion with a collapse in view of tracheal shift, and the strong smoking and constitutional symptoms which were there. CNS, probably an acute onset vascular event which would have happened because of his because of the risk factors he has, probably localizing to the posterior circulation with the in the brainstem with cerebellum and its connections. Probably could be a multi-infarct state or could be on the brainstem localization. So right lung mass involving the right middle and lower lobe with collapse, acute stroke syndrome in the brain, posterior circulation, right third nerve, cerebellum and its connections.
So the symptoms resolved, right?
It's resolving, sir. Currently there is no
resolving
ptosis,
symptom.
there is no down and out eye, sir. Right now it's resolving.
So the comments. Comments.
Yes, probable lung mass. I'm not saying it is lung mass as of now. The history was suggestive of a probable underlying malignancy because of constitutional symptoms. Lung collapse is what the clinical diagnosis would be, ma'am.
Your trachea you'll expect to
It to be shifted to the other side. Yes.
So the mass may not fit in. Collapse.
Sure.
Yes.
Collapse. Sorry.
Point, mass is a pathological diagnosis. You can't,
Sorry.
if you're just trying to say that you think it's a neoplasm based on the presence of
Yes,
constitutional
sorry.
symptoms, you shouldn't say mass. Clinically, you
It's
haven't
like
found any
lung
evidence.
collapse. Sorry.
The etiology may be malignancy. It does not need to be a mass.
So if a person has a collapse, no, what are the diagnoses you have to consider other than lung malignancy? What else can cause collapse other than malignancy of the lung? In children, what will you think of? What's very common? Huh? Foreign body, right? So you can get foreign bodies, peanuts, which fall into the right main bronchus that can cause a collapse. What else can cause collapse? So you can get mediastinal nodes, hilar nodes, which press on the bronchus. That can be due to TB, also can cause a collapse of the. Sometimes just a mucus plug can cause a collapse. So the diagnosis of collapse, yes, in this setting, definitely central mass is a possibility. Usually when we say mass on the clinical examination, there should be clear-cut findings of a mass. Here we can say that this patient has symptomatology suggestive of malignancy, but the clinical findings are that of a right-sided lung collapse, and the differential diagnosis includes malignancy, and also you have to rule out other causes of a collapse of the right lung. Comments? Bennett, Jennifer. So what is your approach to the diagnosis of this patient? How are you approaching his diagnosis?
So, I would like to first, do a chest X-ray and to confirm my findings, and then evaluate based on that, sir.
Want to show us the chest X-ray? We don't have. We have access to it, no? So how common is lung cancer? What proportion of cancers in India are due to lung cancer? About 6%. Okay, and in men it is the second most common cause of cancer. Women it is much lower down. Can we access or so? You can tell us the X-ray findings and the what did you?
There's a right-sided hilar homogeneous opacity with right-sided tracheal deviation, and also there is a right hemidiaphragm which looks pulled up, sir.
That suggests
That is
there could
collapse.
be a phrenic nerve palsy also with the paralyzed right diaphragm.
Okay.
No effusion, no?
No effusion.
So when we look at the X-ray, what are the usual findings we look for a lung mass, for a lung cancer? What are the common X-ray findings? Most commonly, we look for the coin lesion. Coin lesion of the lung. The other, you can get an effusion. The other findings are like hilar mass. Then there's lymphangitis carcinomatosis. So you can get like a miliary mottling of the lung if there's a lymphatic spread. So these are all the common mediastinal widening if there's mediastinal gland. So these are all the things that we look for. And then how did you proceed? Your CT scan, what did it show?
Sir, the only preliminary report is available. The preliminary report showed a right-sided. There's a right-sided perihilar lesion with the peribronchovascular spread with regional mediastinal and non-regional nodes are also present, sir. Yeah. Non-regional.
Size of the mass?
They hadn't reported. They've not reported the CT yet. We have
What are you trying to confirm your diagnosis?
So we had initially sent because TB was still in consideration. Initially, export was sent. That is negative. No, we had sent sputum cytology, which showed atypical cells. So we went ahead with a bronchoscopy and biopsy, sir.
So sputum cytology can be useful. So about 15% of people may be positive on sputum cytology. So it's a useful test. Here you found atypical
Scanty
cells.
atypical cells are
You
there, sir.
ruled out tuberculosis.
Yes, sir.
Then you went for a bronchoscopy.
Bronchoscopic.
What did that show?
So they've just done it. So they have taken a TBLB. They export everything else.
Was there a mass endobronchially?
There is endobronchially, they couldn't navigate beyond the right main bronchus. There is some invasion also. That also, sir. Final report they've not
Biopsy has
given.
been done and is awaited.
TBLB is done. It is awaited, sir.
I don't know. I thought it was something. Yeah, this is that section like this. Something is there on the right. Could be.
So here, what are the key things which can determine the likelihood of malignancy here is now 99%, right? It almost looks like a conclusive diagnosis. So what are the things that will affect his treatment and outcome?
The type of malignancy and
Okay, one. So what are all the types of lung cancer?
small cell and non-small cell.
Okay.
Non-small cell adenocarcinoma, large cell carcinoma,
And
squamous
cell carcinoma.
carcinomas
So the small cell carcinoma and
was
the
outcomes.
large cell carcinomas, and that is squamous, adeno, the bronchoalveolar carcinomas. And so one is the histological type. What else? What are the things which affect the outcome?
The molecular status nowadays,
So
PDL1,
what about his
ALK,
performance status? What do you mean by performance status?
ECOG, the basically if he'll be able to tolerate the chemotherapy and the further.
So he has a younger age, he looks quite well, but he has a poor performance status that will definitely affect the outcome and the presence of comorbidity. So if they are there, that can affect the outcome. So we're interested, and then we need to know the staging. So how do we stage lung cancers? The TNM staging, right? So what is the principle of staging? So stage 4 is where there's metastasis outside the lung, and stage 1 is where they're very small lesions. So 1 and 2, and then stage 3 is if there are involving the neighboring structures like regional lymph nodes. So staging, all these become important in. And then you mentioned about looking for mutations, right? What are we looking for?
Today we have there are immunotherapies available to target. So we have PDL1, ALK, RAS, and outcomes are different for each of them. Few like ALK and all have much better prognosis than the other, and if they are young, and they also predict type of ones with CNS metastasis also, or what type of further prognosis also it will be helpful, sir.
The questions.
I'm not exactly sure, but one of them, ALK or RAS, one of them have a predilection for this patient, ma'am. Actually, multifact infarct he has. Actually, he has triple sign. He has both bilateral anterior and posterior circulation strokes, multiple infarcts, small tiny focus of multiple infarcts, ma'am. Actually, bilateral anterior and posterior circulation strokes, tiny foci. We have done echo, that is there is no thrombus on the CT. I mean, limited CT we have done, that discuss didn't show that, but we are carotid Doppler is not done yet that we are doing, but that wouldn't explain both posterior and anterior, the arch. He has infarcts, sir.
Shall we close the discussion? Any other questions? Thank you.
Thank you, sir.